Can I welcome you all to the virtual Health and Social Care Scrutiny Subcommittee meeting? Present are members and advisors of the subcommittee, council officers, partner organizations, and portfolio holder for adults and public health. Can I refer members and officers to the published protocols for holding virtual meetings? Please note the following. Members of the subcommittee should ensure they have their videos on at all times to put microphone on mute unless speaking. Other members and officers should switch off their videos and put the microphone on mute until they are invited to speak. In case of technical problem, the meeting will adjourn until the issue is resolved. If the technical problem persists, then the meeting is incorrect, the meeting will be abandoned and rearranged for later date. The meeting is being audio and video recorded and will be available to watch, listen it on the website. Item 1, attendance by reserve members. There are none, right? Declarations of interest. Do other members in the committee have any more declarations of interest to make? Natasha?
Hi, I'm not sure if this is necessary completely, but I just wanted to make it clear. My mother was under Vernon treatment for cancer a few years ago, and she's had a recurrence of her cancer. She hasn't been referred there yet, but I think she might be in the future. So I just wanted to make that known.
Thank you. And minutes of the last meeting, can we approve the minutes?
Sorry, Rita, I just wanted to.
You want to declare?
Raise my hand, but it didn't happen.
Okay.
We'll go through the agenda. If there is any item where I feel I need to declare, then I'll just let you know at that time.
Hand up if your things doesn't work.
Yeah. Just trying to do that, but then you started.
No, then on. You can put your hand up and come on the camera.
Yeah, sure. Yeah, definitely.
Hi, Janet. Would you like to?
Hi, Rebecca. Yes, for Mount Vernon Cancer Services, I was treated there a few years ago for cancer. Thank you.
Okay, thank you. Anyone else? No? Can we move on to minutes? Can we approve the minutes of the meeting held on 19th of November 2020? Agree? Minutes approved. Yes, public questions.
Okay.
Sorry. Somebody is prompting something. Can you please make sure you're on mute? Item 4, public questions. No public questions have been received. Thank you. Item 5, petitions. Are there any petitions? We haven't received any. 6, reference from the council and other committee and panels. There are no references. Now we are moving on to item 7, Mount Vernon Cancer Center review update, November 2020. We would now have a presentation from representatives of NHS England and NHS Improvement. Would Ruth Derrett and Jasmine Kinghorn introduce the report in brief, please?
Yes, thank you very much, Chair, and thank you for having us back. It's good to see everyone again. I have got a presentation which I will run through, some of it very quickly, and then we can have a discussion afterwards, if that's okay. I'm going to share my screen, which I hope will work.
Okay.
Right. Are you able to see? Are you able to see that slideshow?
Yes, very clearly.
Yeah. Thank you. Okay. So what we thought we'd do is if I just run through this presentation, and then we'll take some questions afterwards. And Ruth's here, and I believe that Susan Sinclair from North West London ICS has joined as well. if there are any questions that are particularly pertinent to the sort of ICS and the cancer strategy for the area. So you'll recall when we've come to you before that we're talking about a cancer centre population with about 1,000 patients from Harrow treated each year, which is about 9% of the population. The area that Mount Vernon serves is a very, very big area, and it covers all the way up to north of Bedford, and it goes down into sort of the northwest London area, as well as off to the east and to the west. The darker purple on that map is the area that the majority of patients come from, with Mount Vernon being down towards the bottom left end of its catchment area. In terms of specifics, about 11 to 12,000 events happen at Mount Vernon Centre for Harrow patients, and those events will be everything from a chemotherapy appointment to an outpatient procedure, and I will explain in a little bit more detail. And you can see there that it's quite a big user of chemotherapy compared to some other areas, but less so for inpatients. So these are some of the numbers that we're talking about, and I'm not going to run through all of them, but just to give you a little bit of a feel for the number of patients that we're talking about in a little bit more detail than we have done previously. So 159 patients in 2019-20 had chemotherapy at the Mount Vernon site. Obviously, some patients will have had their chemotherapy at Northwick Park, but some patients need more complex chemotherapy. And with Harrow, what we find as well is that there are some patients who've chosen to have their chemotherapy at Mount Vernon, usually because their clinician has moved. That's the sort of feedback we've been getting through the patient feedback. You can see further down that list that 366 patients have radiotherapy at Mount Vernon. So we're talking about 5,000 sessions a year of radiotherapy, and there are some inpatients, there's some palliative care and various other appointments as well within that. I won't dwell on this because we've spoken about this before, that you know the services needed to be reviewed for a long time. People have been struggling to find a solution really for some of the challenges that the site faces, which don't just include the state of the buildings, they include some of the clinical pathways and because of the lack of some of the support infrastructure that's needed for modern cancer care. And we've had some independent advice given to us about what we should do and what some of the challenges are. And you can see here that there is a lack of intensive care on the site. There isn't the co-located acute support that's needed. With increasing amounts of comorbidities of patients as people live longer and they live with cancer and with other illnesses for longer, we're needing to be able to treat more conditions side by side, which we can't do at the moment. And we have a lot of complex arrangements with other trusts. So, for example, anaesthetic support comes from Hillingdon, but when cardiology support is needed, Harefield is called. And I'm not going to dwell on a lot of the examples because we have been here before with them, but we're happy to share some examples for any members who might want to pick those up in the questions after, who maybe could do with a little bit more information. And obviously, one of the really exciting things at the moment is that there's a lot of new cancer treatments. It's a really exciting time for cancer care. But without some of those support facilities, Mount Vernon's not going to be able to deliver everything it could be, and staff won't be able to treat the more complex patients or get some of that experience which they need. So we asked for a second independent review just to confirm what we mean by co-located services. So what acute services need to be on a site. So obviously intensive care we knew was one of those, but we wanted to be really clear in what we were looking for. And their view was that there's quite a range actually, including the ability to be able to consult with specialists for things like gastroenterology, endocrinology, infectious diseases and so on. So basically the full range of outpatient care, including quick access to urgent physiotherapy services when needed as well. And the clinical group have done a lot of work, as you know, to look at the potential clinical models that we could use in the future. They have looked at patient feedback, at staff feedback, at a whole load of data. They've looked at best practice. They've spoken to other cancer centres, and their conclusion was that we need to go for a full replacement of the Mount Vernon Cancer Centre on an acute site. The independent clinical report had recommended 2 potential models. One was a full replacement on an acute site. The other was moving the service to an acute site, but perhaps leaving a little bit of it behind so that there was some outpatient service on the Mount Vernon site. The reason that they've recommended the full replacement model, there are a number of benefits that they think there are to that, and it's also in line with what patients have said about wanting to keep the team together, being able to do more specialist stuff if we move everything, but also from some of the areas that are further away from the centre, a feeling that if you had a secondary centre, it still would prove an access challenge, and they would prefer the resource to be spent looking at how some elements of care could be closer to all patients. So how we can improve access to chemotherapy at local hospitals, and how we can improve access to radiotherapy, and even blood tests. Blood tests came up an awful lot in the patient engagement. People travel long distances for a blood test to see if they can go ahead with their chemotherapy. And so that was what the clinical group recommended. Each ICS also had inputs into the programme. They were asked to share their views, their plans for cancer services, their challenges in their populations. And so we've gone through all of that. They were all talking about health inequalities and wanting to do some work to try and reduce health inequalities. The ICSs that were outside of London were particularly concerned about long journey times that their patients have, and there was some cancer outcomes data that we looked at that showed that in particular Luton was of concern in terms of outcomes. Access to radiotherapy is also an issue, and we've got various areas that are particularly affected by that, particularly around the northeast of Hertfordshire, South Bedfordshire, over in the Frimley ICS area. And Northwest London talked about their intention to give patients the choice of other facilities. There's a lot more choice around the London, particularly the southern London area. And also access to chemotherapy was something that came out of the ICS conversations, and that perhaps we could do something through what we've called a distributed chemotherapy model, which basically enables it to be delivered in a number of different places, and looking in particular at the fact that Watford and Hillingdon hospitals don't provide the chemotherapy services at the moment for the Mount Vernon population. Those patients have to travel into the centre. So I'm rattling through it, but hopefully the questions can pick up anything you think you want more detail on. Mm-hmm. So the programme board in December considered all of that feedback as well as all of the patient engagement that we've done, and they supported the recommendation of the clinical group for a new single site cancer centre on an acute site, alongside improved access to chemotherapy, consideration of radiotherapy, and to see what else we could do to improve access for the local population. There was a big discussion around health inequalities and cancer outcomes, and a piece of work has been set off in the Luton area in particular to start to look at how we can address that. And they'll be learning from that we can apply to other areas as well. And we noted that only one acute site actually fully met the criteria that had been agreed, and that had been developed with the input of patients. And so just coming on to that, the criteria, there were 5 main points. That the site must have critical care as per the independent clinical advice, that it must have the range of co-located services that we'd been advised were necessary, and that there should be no more than a 5-minute increase in average journey times by car for the population that the centre serves. There should be no more than a 5 percentage point increase in the proportion of patients with 30-minute plus journeys. And for public transport, that we shouldn't see more than a 5-minute increase in travel time for journeys on public transport, but also because some of those are very, very long, no increase in the proportion of patients that travel for more than 75 minutes by public transport. And the analysis was conducted independently. It was based on a 9 o'clock on a Tuesday, so not peak rush hour, but not too far outside either, so a bit of an average time. It was done on timescales before COVID, before lockdown, so when there was plenty of traffic on the roads. What I would say is, because for patient confidentiality reasons, the data was grouped at GP level. So the travel times are based on GP surgery to each of the sites. And so for some rural areas in particular, we're picking up that there's probably an additional time. So this is probably best case scenario in terms of the travel times we used. But you can see there that Watford was the only site that met all of those criteria. And so the programme board decided to do some more work around the Watford option as being the realistic option. And at that programme board, we had each ICS was represented. We had Healthwatch Hillingdon as well as Healthwatch Hertfordshire. And so there was a balance of representation from North West London as well as from the east of England. And these are just some slides showing some of those travel times. This is for Harrow is highlighted here, and you can see the journey times for Watford for each of the CCG areas. And for Harrow, the average travel time increases from 20 minutes to 23 minutes compared to the current site. But you can see that with the exception of Northwick Park, every other option would have been pretty much worse. And Northwick Park, you can see, because we've got all the figures in there, you can see what difference that would have made to some of the other areas that we're talking about. And this is just the same data. This is car journey times for some of the other areas that we're looking at. So you can see there some of the longer drive times that some patients have. We've also looked at the areas that are have the highest deprivation, and we've looked at the public transport in particular. And so you have here Luton with obviously very long journey times. It comes down slightly, but it's still very high at Watford. I think it would be high pretty much everywhere. And we've looked at deprivation of areas. We've looked at a huge range of data. I'm just whizzing through this, but we've got here these are the 1 year and 5 year survival outcomes. We have it for all areas. These are just showing the three that are the most deprived areas. Harrow is about average. It's good at 5 years. It's about average for 1 year. Luton is the only one that was red for 1 year, and red for the east of England was red for 5 years. So that's why that one's been of concern to us. So in terms of the patient and public engagement that we've been doing, we've had low turnout altogether, but we've had good turnout from Harrow comparatively to other areas. So about 22% of patients engaging before Christmas were from Harrow. And what we're finding now is that it's probably around about 22% still, and maybe a little bit less. But we're finding that about 2/3 of people that are getting involved at the moment are new to the programme. They haven't been involved before. I've just realised there's a typo on the slide. I'm terribly sorry. There have been 10 people taking part from Harrow in February, so it's not a big number, but a lot of them do represent other patient groups and so on, including Healthwatch. And we generally find that people from Harrow are reasonably content with both the clinical model and Watford being the option. And what I would say for people in North West London, I have been really impressed by how open-minded they have been to thinking about the whole of the catchment for Mount Vernon and understanding some of the complexities in terms of the difficult and different journey times. We've also launched an interactive website. We launched it at Christmas time, New Year. And we've got about 160 people who've registered with the site, so there are other people visiting it. We've had, as of yesterday, we'd had 1,400 visits to the site since it launched. You can see there that of the people who have registered, 22% have a Harrow postcode. So there's something about the 22%, it keeps coming up for Harrow. And yet you have 9% of the population, but 22% of the engagement. So a very engaged, comparatively, population. But what we're finding is people are really taking part. So there are people who are actually asking questions on the website, telling their stories. So we're hoping to really grow that as we go through this process. So I think we're coming to the end. This is the last slide. So I just wanted to finish really by saying, where are we at? What are we doing right now? And we can maybe go into a bit more detail afterwards. So we're working with West Herts hospitals and with UCLH and others around looking at the Watford site option. Is it feasible? How would we do it? What would it look like? Not the sort of physical design, we're not at that stage, but just in terms of how much space do we need? Is it possible? We need to answer the is it possible question quite quickly. You'll recall the clinical model that we decided was the preferred one would be for a cancer centre on an acute hospital site, which in this model would be Watford, but with improved access to chemotherapy. And Watford and Hillingdon were the two hospitals that didn't have chemotherapy. So we're talking to Hillingdon hospitals about developing a chemotherapy service so that their patients, there are about 3,600 patients a year that go to Mount Vernon for their chemotherapy from Hillingdon. So the plan would be that if we had a chemotherapy unit at Hillingdon, the majority of those would have their chemotherapy at Hillingdon, not at Watford. We're looking at networked radiotherapy, so we've been having discussions about whether there's enough activity for a second radiotherapy site, probably in the north of the patch, so Luton and Stevenage, somewhere around there. And we are looking, as I mentioned already, the work on Luton to try and understand those outcomes and doing some really kind of looking underneath the data and trying to really make sure that we really understand what the data is telling us around radiotherapy uptake in particular. And Harrow is one of the areas that will be really interesting to see how that plays out, because there's a potential that uptake is quite low in Harrow, but we're testing that at the moment. We're working on the transfer of the management of the services to UCLH. You'll recall one of the recommendations from the clinical panel was that the service should be run by a specialist cancer hospital, and we went through a process and appointed UCLH as the preferred provider. And we're going through a period of due diligence at the moment, which is leading up to their board making a decision, which will be later this year. And we're updating the timescales for the programme because, as I'm sure you can imagine, we've kept this programme going. We had a pause last year when wave 1 of COVID hit. We've tried to keep the programme going through this latest wave, but the hospitals that we are working with have been under incredible pressure, and particularly some of the clinical work streams we have had to slow down, and that will have a knock-on impact on our timescales. So whereas you may remember we had got penciled in public consultation, June 2021 at the earliest, that's very, very unlikely to happen now. It's more likely to be September at the earliest, but we're revising that timescale at the moment, and we will publish that with our next stakeholder update, which is due out in the next couple of weeks. And then we haven't been ignoring the site. This isn't a case of let everything rot whilst we develop something flashy and new. We have been looking at what we can do for the current services. So we've agreed and secured funding for a new linear accelerator machine to replace one of the existing ones that's got to the end of its lifespan. And that will be going in July this year. We are expanding outpatient capacity so that doctors and their teams have more room to treat patients. That's something we've picked up through the patient engagement, that there hasn't been enough space, and we've found a way of doing something about that. We've made some ward improvements like call bells and just simple stuff that improve patients' experience. And we're in the process of updating the computer system in medical physics. Just some examples, just to give you some reassurance that things are still being maintained. There's a group that meets fortnightly to ensure that. And then importantly, we're having the capital funding discussions, trying to make sure that we are on the radar, that this is a priority, and that we won't be going out to public consultation until we have secured the funding that we need for this development. But that hasn't been landed at the moment, so we are still working on that at this stage. And patient and public engagement, I've already mentioned, we're in the middle of a cycle of activities. There's a lot of events. There's 37 online events that have been taking place between January and the end of March. Shortly, in the next few weeks, we'll be publishing the next lot of events as well. And those events, the events we're in the middle of at the moment are very much focused on trying to understand the impact of a Watford solution on different geographical areas. So what does it mean for Harrow patients? What does it mean for Bedford patients, and so on? So I'm going to stop talking there, if that's all right. And I'm sorry that was maybe a little bit longer than you'd have liked, but I just thought it might be useful. It's a big programme. I thought it would be useful to run through everything. And I apologise if that was too fast.
No, that's fine. Thank you. You're very good. Okay, questions, people? Michael? Yes, Michael Boria.
I think Tasha got in ahead of me.
Okay, sorry. Tash, then Michael, then Veena.
Thank you, Michael. That's very kind of you. Just a couple of questions. First of all, thank you for the presentation. It's really useful to see everything laid out again, and all of the stats and public engagement was really, really useful. I just had a quick question to ask about staff as well. So the staff we have at Mount Vernon at the moment, what sort of consultation, really, I guess, and work has been done with them? What's the general feeling from the staff, and do we have any idea about kind of retention? And yeah, that's my first question. Thank you.
Yeah, that's a great question. You're happy for me to go ahead and answer that straight away?
Shall I wait for 3 people and then you'll give the answers, if you don't mind?
Okay.
Yeah, so Michael next and then Veena.
Thank you, Chair, and thank you, Jessamy, for the presentation. I just wondered, touching on the point you made about Harrow having a potentially low uptake of radiotherapy services. This is surprising, really, given the proximity of services at both Mount Vernon and Norfolk Park Hospital. I just wondered, how can this really be addressed in the future to improve cancer outcomes for Harrow residents without having necessarily to travel, further afield? You mentioned, for instance, looking at Luton, and I'm just wondering how we can maybe improve those services at a more local level in Harrow. Thank you.
Veena.
Thank you for a very clear and nice presentation. My question was, we've already, the staffing was touched upon. What about the clinical team? Will they be moving with the patients to Watford, or they're gonna go to, as you say, cancer specialist site? And what about if you are gonna recruit new members of staff, not you, but the cancer unit, how are they gonna be delivering the training and competency, and how will it be measured?
Thank you.
Thank you.
Okay,
Shall I start and pick up some of those, Jessamy?
Yes, that's fine. I was going to take 1 and 2 and then 1 and 3 and then hand over 2 to you anyway.
Do you want to do that then, and I'll pick up radiotherapy?
Shall I do that first then? So staff engagement, absolutely. We've been talking to the staff in a number of ways. They have regular team meetings and team briefings, but I've also done some staff engagement sessions in much the same way that I've done some of the patient workshops. I've done a mixture actually of face-to-face and online with staff. Before we went into lockdown, I was able to, last October and November, go onto the site. There's a room that's quite big and all spaced out. And I've also done a survey that staff can complete either on their own or with their teams, which is a sort of freehand survey where they can really think about what they want to get out of a move, how they're feeling about it, and so on. I've done a number of those events now. I've done some that I did one specifically with the consultants. I've done one with the Paul Strickland Scanner Centre. I've done several with sort of the whole staff workforce. And I would say they are excited about the move. They are optimistic about the move. I've had one person say to me they don't intend to move with the service. That was an admin member of staff, and he was very upfront about it. He said he does the job he does because he wanted an admin job close to home, and Mount Vernon was there and was recruiting, not because it's a hospital or it's a cancer service or anything like that. So he will just look for another local job because that's what he looks for in a job. The clinicians, they're excited to be working with Watford. That's the feedback I've had. I've not had any feedback at all to the contrary. There was some concern from consultants and from other clinical staff about whether this could happen and what their options would be if it didn't. They have other job offers. They have other hospitals they can go and work in. They are very loyal. That's the feeling I get. Very loyal to each other. Very loyal to their patients. I've asked them all directly, actually, what motivates them to work. Why are they still coming to work at Mount Vernon? And I've had things described like there's light at the end of the tunnel now you're doing this review. They are very frustrated that they can't deliver the level of care they want to. And it's not their ability or their care for their patients or anything. It's purely that the facilities just don't exist for them to do what they want to do. And I think there's only so much of that they will put up with before they start looking elsewhere. So it's really important for staff morale that we get to some decision points reasonably fast as NHS schemes can move, and we can give them some certainty. I think if we struggle with that, then we might be looking at a problem. So it's not a case of we're moving a service and the staff are all going to disappear. It's actually if we don't move the service, we might lose the staff, I would say. And in terms of clinical team, it's the same thing. Part of the attraction of moving the whole centre is that we take the whole clinical team with us, and that they seem to be very excited about that. They've been quite disappointed that we had to postpone a clinical meeting with the Watford staff because of COVID. Training, we haven't got into that level of detail, to be honest, but it will happen in the same way it does at the moment. UCLH, if they agree to take on the management of the service, will have their own ways of doing training, of monitoring training, of measuring it. So I wouldn't want to preempt what they would do, but the service would be being managed by a specialist cancer centre that does that routinely for all of its staff at the moment anyway. And so I imagine that it would only get more aligned to sort of how a specialist cancer centre would do it than anything else. So I was going to just hand over to Ruth. I don't know if you were trying to come back on that specific point, but I was going to hand over to Ruth about radiotherapy otherwise, and just suggest that might be one that Ruth's got more detail about than I do.
Yes, can I just add on a supplementary? Based on the staff, you said, will there be any redundancies, or how will it sort of affect the staff? And you said the morale is quite high, but we don't want to sort of pour morality in the workforce as well. So yeah, if you could.
Yeah, no, I understand that. We are a long way from any level of detail on that. What I would say is, because we're moving the service as it is, and we're not expecting to sort of be shrinking hugely or anything like that. We don't have that level of detail, but we do have gaps in the workforce as it is at Mount Vernon. We do have vacancies, particularly around some of the clinical roles, and so it's not something that I would foresee, but at all. But because we haven't got to that level of detail, I don't want to say. I want to say something more certain than that, but I don't think I should, because we're not in that level of detail. But I think it would be extremely unlikely.
Yes, I mean, I'll go a little bit further than Jessamy on that and say I think I think redundancy is highly unlikely in this re-provision. And can I just add one point about the staffing, which is that all the staff moving from one site to another have GP rights under that process. So every member of staff has those GP rights, and of course some staff may choose not to go, but that is very much their choice. That GP right exists in law. So so we'll be progressing with that when we get to that stage. If I just pick up briefly on the radiotherapy in general, and then I think Susan might come in particular around North West London and radiotherapy. So the first thing we need to do in terms of the low uptake is to really understand the data that we've got. So at the moment we've got national data, which we've got from a whole host of data systems, and we're looking at those areas where that data appears to show low uptake. It's very difficult to dig into what the causes of that low uptake might be. So the first thing is to confirm the data, and the second thing then is to start talking to patients and clinicians about why uptake figures might vary by patch. I would suggest that, and this is without us having done the work, so if I can caveat it in that way, that because actually you're very close to Mount Vernon in your patch, it's unlikely to be about geographical access. I think your travel times are sort of 20-25 minutes, so well within the national specification expectation that we would have. So it's really unlikely to be about geographical access. So if we confirm that the uptake is lower, there will be other factors that are leading to that, and that's what we need to explore. And I think that's where we'll start to talk in more detail to your patient groups to just really understand what's happening there. And that work, we haven't done that. We're at the stage now of confirming the data, understanding the additional work that we need to do to have those informed conversations. I think the move to Watford, we're having an inequalities assessment, impact assessment carried out, which by Public Health England, which will be available at the end of March with headlines, and then there will be further work that needs to happen to explore that in more detail. And what they're going to be exploring are the benefits and also the disadvantages of any move, and which sections of population might be disadvantaged by a move. That will then generate some additional work to understand what the advantages are, what the disadvantages are, and how we mitigate those changes so that we don't disadvantage the populations. So that's an overview of how we're approaching it. I know, Susan, you wanted to come in terms of some of the specifics about radiotherapy in North West London.
Yeah, I mean, I think important to really emphasise and building on Ruth's point that North West London and the wider project board have been working very closely to make sure that people are not disadvantaged. So in North West London, the disadvantage around travel time is a lot less than, say, Luton. And what we want to make sure is that during this process, we don't increase that disadvantage. And so one of the things that we are working through with East of England is how to increase the radiotherapy access at Imperial. So for the patients that are at the lower end of the boroughs that may find it easier to get to Imperial, they can choose to do that, or they could go up to Mount Vernon. So that, and we know that people already choose a bit as it is. So I think we're quite committed to working for care closer to home. That's particularly important for chemotherapy. For radiotherapy, you've got less choice about where you site linear accelerators because of the infrastructure required. But one of the things that we've agreed with the East of England Programme Board is that we will make sure that we augment the services in North West London to make sure people aren't disadvantaged.
Okay, thank you. Meena, did you want to come back, or shall I move on to?
Yeah, can I just?
Yes,
thank you.
quick one.
What I was going to ask you was, what about I know I did ask you, but just because it's a full committee, about the equipment transfer and the site allocation of the equipment. It's all going to be Watford site. So have they got enough room to accommodate all this radiotherapy equipment?
So shall I pick that one up? So the short answer to that is what we're doing at the moment is trying to identify the amount of space that would be required on the Watford site. and to look at that in the context of the new Watford Hospital, which is being designed at the moment, as I'm sure you know. So the short answer is yes, they do think they have sufficient space on the site. The clinical team are very excited about having the cancer centre on the site. It would be a separate cancer centre co-located on the Watford site. All of this is obviously subject to consultation and money and all of those good things. So it would be co-located on the Watford site with a link to the main hospital. The cancer centre would be managed by UCLH, so not by Watford Hospital, but they would clearly work very closely together. So those conversations are happening at the moment. One of the areas that we're exploring with Watford is about whether, with their build, it would be feasible to build the cancer centre at the same time, or whether it's necessary to do those things consecutively, which would obviously delay the time that, delay the time that we could actually make a start on that. We think we're having a positive discussion around that, and that it would be possible to do some of that in parallel. But there's a lot more work that needs to go in at the design stage to confirm that.
Thank you.
Okay, Councillor Livingston. Want to ask your question, Councillor?
Yes, thank you, Jessamy. That was very informative and very clear, your presentation. Thank you for that. I just wanted to pick up on one thing again about the radiotherapy. You mentioned about network radiotherapy, and I was wondering how this would be managed as far as the staffing and equipment is concerned. Any ideas of how this may, this may look like?
So if I pick that up initially, so we've got a three-stage process to answer that question. I'm afraid we're not doing anything quickly. So we've got three stages to get to answer that question. The first phase of that we completed today, which is about understanding, is there a clinical case for change? Is there sufficient concern about access to justify exploring in detail networked radiotherapy, so a satellite radiotherapy service? And the recommendation from the programme board, which met this morning, was unanimously, yes, there is. So we can now move to stage 2, which is to understand what the potential locations might be and what the sizing and functionality of a satellite radiotherapy service would be. So we'll be exploring that over coming weeks with the aim of having our thoughts about that clarified by the 16th of April, and then having a recommendation going to the programme board, which will meet in early May. We haven't got the early May date in the diary yet, but it'll be the first week in May. And what we're thinking at the moment is a 2 LINAC satellite, probably in the northern area, as Jessamy said, because that's where you're seeing the longer travel time. So that would be Luton, Stevenage, somewhere in that area. So does that answer your question? I'm afraid we can't, we haven't done all of the work yet to be able to be more specific about that.
Yes, that begins to answer the question. Thank you very much. I was just wondering about the staffing and where they were being located, but it's still early days yet for that.
It is. It would still be one service split across 2 locations. So I think it would still be a part of Mount Vernon Cancer Centre, but obviously with a remote location as well.
Thank you.
Janet Moat, would you like to ask your question? Janet.
Thank you. Yeah, that's perfect. Thank you, Jessamy. That was really super. I just wanted to ask about 2 centres there. I wanted to ask about the Paul Strickland Scanner Centre, and also about the Linda Jackson Macmillan Centre. And are they staying on the site? Are they moving, or what's going to happen? Thank you very much.
Okay, thank you. So I'll take that straight away. The Linda Jackson Centre is the currently the #1 topic that comes up in the patient events. It is very, very well loved. As it stands at the moment, both those services we think are quite critical to a future cancer centre, And in our calculations about how much floor space we need and what facilities we need, they are in the calculations. The Paul Strickland Scanner Centre is an independent organisation, so will have to make its own decision. But their chief executive sits on our programme board and is very much part of the process. And I've spoken to their staff, they're very engaged in the process. And the Mount Vernon staff think that the Paul Strickland Scanner Centre is absolutely critical to move to. So the plan is that they would both move. I know that there is some local interest in the Linda Jackson name, because obviously it's the fundraising for it has been very, very local. And there has been some suggestions that perhaps if there is a future health facility on the Mount Vernon site, that the Linda Jackson name could be associated with that, whether that's whatever that looks like. But the main function would move to Mount Vernon. But we are starting to look at some of the discussions that I've been having, and some of the patient workshops have been about how can we improve cancer outcomes closer to home, and whether the Linda Jackson Centre could do more outreach into local areas, because you get people at the moment travelling from Bedford and Luton to classes not at the moment because of COVID, but in normal circumstances, to classes at the Linda Jackson Centre. And I've heard stories about people who've driven all of that way, or somebody who got public transport all of that way. And then one of them, the public transport that was late, the other one they drove all that way, couldn't park, drove round and round and round, had to give up and miss their class and go back home. And it feels like there's something that we should be able to do around that. It's a really difficult one to quantify because it's not routinely funded or anything like that. But we do need to start thinking about other ways of measuring the value that a service gives to patients. And I think that is a really, really important service. My intention, I said we're planning some more patient engagement events over April. So this term, I'm thinking in terms because I've got children and it's easier. But with this term, we're focusing very much on geographical locations for our engagement. Last term it was cancer tumour sites and types we would talk to people about. Next term it's going to be things like the Linda Jackson Centre, and you'll find that we will promote particular events that are around getting patients together to talk about that and what it's meant to them, and to try and find out, make sure that we fully understand really the benefit that offers to patients. And probably similarly with the Paul Strickland Scanner Centre. Both of those, it's a very long-winded way of saying yes, they're both in the plan.
That's lovely. Thank you very much. I mean, the Linda Jackson Centre is very close to my heart because it was so supportive for me and for my family when I had cancer and that, and they were absolutely fantastic. Now, I do know that my husband just wanted to say a quick word as well.
One quick word, just to say a slightly declared interest in the fact I'm trained by Linda Jackson Centre to treat patients as an osteopath. So, yeah, I've done that for a long time. The key thing I'm worried about is a long time ago, I had 19 plastic surgery operations at Mount Vernon. That's gone. Now we're going to get rid of that. And I think, great, going to a wonderful new site, if it's all integrated, I think that's a wonderful idea. But what's going to happen to the rest of Mount Vernon? The buildings that are left are ancient, will always need a massive amount of maintenance. Are we just going to close the site down?
So Hillingdon Hospital are working on what the potential use of that site might be. We're involved in that from a cancer centre perspective, but that's really a question that we're going to have to put, I think, I'm afraid, to Hillingdon Hospitals, because it's their site and they are the landlord of the site, and obviously East and North Herts, which is the current trust who runs Mount Vernon, is a tenant on that site. But we're very keen to be in those conversations with them to the extent that that's appropriate, and we have written to them about some of our thoughts about how cancer patients in particular might be supported from that site, depending on whether they develop a neighbourhood hub of some sort on that site. And I think there's a real opportunity there, but that's very much something that would be in the business case that we're developing. That would sit with the work that Hillingdon Hospitals are doing.
Thank you.
That's lovely. Thank
That's
you
lovely. Thanks
very much indeed.
Okay, thank you. I'm going to ask one question. What are the key headlines from the stakeholder and patient engagement carried out since MVCC review. Colleagues last came to committee. What came out of the Harrow specific events?
Okay, thank you. So the Harrow specific, I can't speak anymore, the specific events. I think what was interesting, there was quite a lot of engagement from Harrow. Obviously, when we were preparing for the programme board in December, we were very much focused on what different hospital sites might mean, what happens for different types of cancer and what people's experiences are. And we found that generally speaking, people from Harrow have quite a good experience. There were quite a few patients that were travelling to Mount Vernon for treatment that I would have expected them to have had at Northwick Park, but that seemed to be because there were one or two consultants that had moved during those patients' treatments, and patients tend to like to move with their consultant, such is the relationship that's formed. I think there was concern from Harrow residents about anything too far beyond Watford. So we talked a little bit about Luton. Some Harrow residents thought that Luton would be okay as an option. Some thought it was just too far. Anything beyond Luton was not, you know, we didn't even get into the discussions. But Watford was seen as a good compromise. In fact, it was actually quite popular. Some people felt the Northwick Park site was very crowded. And actually, I think, as I said, generally speaking, they recognised the fact that there are people that come from quite a long way north, and moving the cancer centre further south would not be in their interest. So, and Watford was a good place to get to. There was some questions that we had around, as there would be for any acute hospital site, and there was for a lot of the others as well, around access to the site and car parking. There were some questions around the fact that there's a football stadium next to the hospital and whether that would cause a problem. We've had a look at how often the football matches are played at the same time that treatment goes ahead, and it's very, very rare. So there was those kind of questions that we got. Nothing surprising, particularly from Harrow, apart from, I suppose, I wasn't expecting there to be quite as much support as there was for a site that wasn't their local one. And I was genuinely very, very impressed by the approach that the Harrow residents took to considering, you know, the whole situation, really.
Thank you. We can send you a few questions if you don't mind, and then not go on and on. But thank you very much.
That's absolutely fine.
Sorry, Veena, have you got a question? You've been putting your hand up. I don't know. Do you have a question?
No. Thank you very much for a brilliant presentation, and it was very helpful. And taking your time out to come and talk to us.
Well, I'm coming to that. I would like to thank the NHS England and NHS Improvement representatives for their time. You are more than welcome to remain on this call for the remainder of the meeting. I appreciate you might have had this a long day, so do feel free to leave if you prefer. The meeting will be recorded and will be available on Council's website for you to watch if you wish. Thank you. Thank you, Susan.
Thank you. And thank you for your time.
Thank you very much.
Thank you. Bye, everyone.
Thank you, Jasmine.
Thank you. Bye-bye.
Thank you. Bye. All right, we move on to next item. Item 8, update on health and social care response to COVID-19, including local infection rates, vaccination program and testing, access to primary care, and staff resilience and well-being. Paul Hewitt, I think, will introduce this item. All yours, Paul. Thank you.
Okay. Well, actually, I'm going to hand over immediately, and be very brief, to Carol and the rest of the team. So, Carol, over to you.
Thanks, Paul. Can people just keep the speak, mute, but just go back to your, that's right. I don't want too many people, and then thank you. Thank you very much. Thank you, Carol.
Okay, thank you. It's going to be a bit of a three-part conversation with myself, Lisa from the CCG, and Angela Morris, our DAF. We're all going to have a little bit into this and hopefully answer any questions that you've got. So I'll start off with presenting the dashboard, which I hope people are familiar with now. So this shows you the current state of COVID in Harrow. Our incidence is 118.6, which is down considerably from where we were the first week in January, where we were almost at 1,000 per 100,000. So we have reduced by about 85% since then. And in older people, similarly, the rate has decreased significantly as well. The indications are that it's going to continue to decrease over the coming week. We're seeing a little softening of the testing rates. So they are reducing, as might be expected, with less disease in the community, less symptoms. And our positivity rate is down to 6.6, which is a much more reasonable positivity rate than we were in January, when we had 1 in 4 tests that were positive. And as you can see, it's 35% decrease in a week. So yeah, we're looking positive. We're not there yet. So hasten to add. So if we just have a look at these two graphs, the first one shows the whole pandemic. So the little purple bump, which seemed so huge at the time, has sort of faded into insignificance almost compared to the number of cases that we've had now. But I need to remind you that at that point we weren't doing community testing, so we don't actually know how much disease there was out in the community. We only know those ones that ended up in hospital, really. But you can see that it's coming down nicely. And then the graph on the right hand side is the more focused look at the last 3 months, and you can see again that the rates are coming down, and the last 5 bars in that graph are subject to some change, but I don't expect them to change significantly, and I certainly don't expect it to change the trajectory. So if we look in a bit more detail at the incidence rate by age, we can see here that in children we've got very low rates at the moment, very low rates in the 0 to 3s. It's only 21 per 100,000. Our highest rate at the moment is in the 25 to 59-year-olds. Unsurprisingly, they're the people who are going out to work, don't have any other option. So they're much more likely to mix with other people, much more likely to come into contact with somebody with COVID. And our other group of significance is the over 80s, which is still a little higher than the average. And that's concerning because those are the people that are more likely to end up in hospital and more likely to die from COVID. So I'll move on and we'll look at ethnicity. The data by ethnicity is it's to be taken with somewhat of a pinch of salt because the data is not fantastic in the way that ethnicity is recorded. But I do know that North West London is having a big push at the moment on trying to improve the recording of ethnicity and standardise it across general practice. And so hopefully that this data will get better as we move forward. The data here shows that in the white, black and Indian groups, we're lower than the average for Harrow. and we're slightly higher in the other Asian, or we're quite a bit higher in the other Asian, which is largely the Tamil community in Harrow. But as I said, the big pinch of salt is this other ethnic group, which has an incredibly high rate still, because we don't think that we've got a huge amount of people who fit into the other ethnic group category, but there's a lot of people being classified as that because of whatever is written in the ethnicity field on their records in general practice. And believe me, there's some weird and wonderful things recorded. So hopefully, when that gets better, those numbers will start to come down as well. The other thing to think about in terms of this data is lumping people together in broad ethnic categories like this assumes some sort of homogeneity that really isn't there. You know, people are very different. The white population includes white British population, which we know is very different anyway, and people have different attitudes within the borough, let alone from different parts of England. It also includes white Irish, and it includes white other, which would include our Romanian community. The black group would include people from the Caribbean, people from Africa, and people who have either of those heritages, but have lived for centuries in the UK. So it does assume, you know, that there are some similarities there. So I'll just have a little talk about testing, and we've got two sorts of testing. We'll start with symptomatic testing. So this is anybody who's got symptoms of a temperature, a persistent cough. As soon as I say persistent cough, I always want to cough. So temperature, a persistent cough, and oh, a loss of smell. Yeah, sorry, I went blank for a moment there. And they can get testing at any of the sites in Harrow, and we've got quite a lot of sites now. And as you can see, the amount of testing that we've been doing has actually been going down, roughly at a slower rate than the rate of disease has been going down, but it's still been going down. So the care home testing is fairly static. The number of home kits has decreased a little bit, and the number of tests that have been done within the community sites has also reduced. Get it to move. Yeah. With our asymptomatic testing, we've got 6 sites which are listed there. And again, the number of tests that have decreased. We had around 6,000 tests a week in January, at the beginning of January, and we've got less than 4,000. I think it's only about 3,500 expected this week. And with that, the number of positives has also come down. Some of that we've been a little hampered by changing government policies. So our original plan was to offer it to schools, and then schools got offered their own testing, to offer it to bigger businesses, and they've got offered their own testing. So some of that has been a little challenging trying to respond. But generally, we're recommending that people have a COVID test twice a week if you have to work outside of your home. So if you can't work at home, then have a COVID test. Or if you live in a household where somebody else works outside the home, you can get tested as well. And so we need to encourage people to have that, because, you know, as we go forward, it's going to be hard to identify those last cases, but those asymptomatic cases could actually spike an increase. And with schools going back, we need to minimise the impact that has. So there's going to be quite a lot of rapid asymptomatic testing being done in schools when schools go back. We've heard about that today as a result of the Prime Minister's announcement. So secondary school teachers and primary school teachers and private and voluntary sector nurseries staff will all be getting tested twice a week, and secondary school pupils will be getting tested in school twice a week for the first 2 weeks, and thereafter they will be testing at home. All the teachers will be able to be tested at home. So we've been trying to increase our testing rates, and we've done various different things. We've been promoting symptom awareness. We've done we've expanded the number of sites. When we were approved originally, we were approved to have 3 local testing sites in Harrow. So our third one is now opened in Kenton Rec, and that's a symptomatic site. And then we have additional testing days at the Civic Centre. So last week we had the testing unit there every day during the week. Brent have opened a testing centre in Northwick Park Sports Pavilion, I think it's called, which is very close to the Northwick Park Hospital. So we no longer have the mobile unit going to Northwick Park Hospital. People will be diverted on the website to this new site in Brent if they need to go at the weekend. We've done mail outs to all addresses in Harrow with a special edition on COVID-19 of Harrow People. And we've done promotional leaflets like the ones that you can see here in the sort of turquoisey colour about getting tested, and it gives some examples of the sort of situations where you might think about getting tested, and then where you can get a test and how to book it, which is very easy. You go to harrow.gov.uk/test, and that will lead you to the link to book a test. We've had COVID marshals going out, also raising awareness about testing with the businesses that they're visiting, but also generally within the town centres, talking to people about coronavirus testing and encouraging people to go to the nearest unit to get a test. And we've been working with the Harrow Business Improvement District in the town centre to encourage businesses, but of course most of the businesses are closed at the moment. So you know, as things start to open up, we'll be working again with them to see about getting them back into the testing unit. And we've done a lot of engagement events and webinars with communities. Some with specific communities, like last Monday we had a great meeting with people of Black heritage, and tomorrow night we've got a general open community meeting. Myself, Sean, Graham, the leader, Genevieve Small, who's the chair of the CCG, Amit Bakai, who's a doctor from the Royal Free, and Patrick Vernon, who is our Race and Equality and Diversity advisor at the council, and is generally, I think, is a cultural icon. So if somebody is positive, then we do have. I've forgotten to put the slide in. I apologise. If somebody is positive, we do have some services that they're available to access, and that includes the Help Harrow scheme, and also if they're a small business, they can apply for some of the business grants. If they are asked to isolate and they're on a low income, they should be able to get one of the payments of £500 for people who are on low income or on benefits. In addition to that, or also alongside that, we have people who are clinically extremely vulnerable, and everybody that we've been notified who's clinically extremely vulnerable has received at least 1 or 2 phone calls. The change in the definition meant that the numbers have fluctuated a little bit. So there was a change in the definition which removed about 600 people from the list prior to Christmas, and then it slowly increased again each week, getting a few more people as the GPs re-added some of those people who'd been taken off. And then another change in the definition at the beginning of or end of the second week of February meant that last week we got an additional 7,000 people onto our clinically vulnerable list. So it currently stands at about 21,500. And as I say, we've contacted every single one of them. Around 20 households every day receive food delivery through our helpline. Half of those are people who are clinically extremely vulnerable. But a much more significant number have received food through the local food networks and the amazing work that they do in supporting people who are suffering hardship and isolation. One of the things that we anticipated that we would be asked to support is picking up people's prescriptions and things, but we actually didn't have any requests for prescriptions. So that was a bit of a surprise, but we believe that's because most of the community pharmacists will offer delivery for people who have to isolate because of their vulnerability. And some of the pharmacists have an automatic delivery, like Lloyd's Pharmacy, I believe, have a postal system. And the most common reasons for people asking for help through the Help Harrow scheme was due to ill health or disability reasons, and then followed closely by being made unemployed or delays to their benefits or financial hardship. Go on to vaccination, and I'll bring Lisa in here.
Thank you, Carol. Thank you for handing over. So good evening, I'm Lisa Hinchin. I'm the acting Borough Lead Director in Harrow and have been leading the vaccination programme alongside Dr. Genevieve Small, who's on the call as well this evening. Just to give you a brief overview of vaccinations, first of all, I think a lot of people are familiar with the vaccination programme, so I will give the overview and really happy to pick up any of the detail in questions afterwards. So there's really 3 ways in which we are delivering this vaccination programme in Harrow, and which the CCG is supporting. The first of these, and the first that were to get up and running in terms of vaccinations, were our COVID vaccination centres. I'm sure many people are aware that we are operating those across 3 sites, at the Hive in the east of the borough, Tithe Farm, Rayners Lane, and in Byron Hall in central Harrow. These centres are led and managed by our primary care networks, who work in collaboration with local practices to invite and deliver the vaccinations for their patients. It's been a really positive development in Harrow that all of our practices are collaborating together to invite their patients to vaccinations, and patients in Harrow will receive a choice of any of these 3 sites to attend. There are 2 other types of vaccination centres that are running alongside these that aren't directly managed by the CCG, but I just wanted to mention. So there are pharmacy sites now operating. We have 3 of those in Harrow, 2 in Rayners Lane, and 1 that has recently opened at Grimsdyke Lodge Golf Club. They are doing fairly small volumes of vaccinations at the moment, but we expect that they will increase over the coming weeks and months. There's also a mass vaccination centre model. We don't currently have one operating in Harrow, although Byron Hall has been identified as the location for the mass vaccination centre in Harrow, and that will work there alongside and in partnership with our PCN site that's currently operating. The second model of delivery is our roving teams. So these are to engage our patients who are unable to attend the centres. So these are for patients in our care homes and our housebound patients. We've been delivering this programme over recent months and have got really excellent coverage of these patients. And this programme is really delivered directly by GP practices, also supported by our community provider CLCH and our GP Federation Harrow Health community interest company to support those roving teams going out. And something that we've been just trying out in the last few weeks are same-day access clinics. So we've particularly focused these around practices that have a slightly lower uptake of vaccination amongst their populations, and particularly where they're experiencing some hesitancy of patients to attend the vaccination sites. And I think we've particularly found that with our clinically extremely vulnerable cohort 4 as we've moved on to them. Some people have expressed that they feel uncomfortable attending the larger sites. So we are able to offer the vaccination within patients' GP practice. So that's provided to a booked list on the same day. So it's a booked clinic that patients can access vaccination there. This model also affords the opportunity to deliver same-day access clinics in a range of sites. So that may be particularly useful as we reach out to communities who we're not seeing such high uptake, and that's definitely an option we have available and something we're actively considering in partnership with Harrow Council. I don't know if I have slide control now. So just to highlight the progress to date, so I've included the data here, which is our latest data that shows performance as of the 21st of February for our age cohorts. The data around the clinically extremely vulnerable is just running a couple of days behind, so that's there from the 19th of February. I have to say we are really proud in Harrow of the work our centres have done and our practices in engaging patients in this programme, and we're seeing some of the highest uptake rates in London, which is just fantastic for our population and the protection of them from COVID-19. The targets that we've been working to are 80% uptake for our over 80s and 75% uptake for the remaining cohort groups. So our performance is well exceeding those targets, as we always hoped it would, so that we could cover maximum population. So this is the 4 cohort groups, as people will know, was the government target to be met by the 14th of February. We are now moving to our 65 to 70-year-olds, as well as the under 65 at-risk population. So that's the population who would ordinarily receive a flu vaccination. We are busy with clinics at the moment running vaccination for those patients. I think it's just worth saying, I think these figures are brilliant, but they do hide some disparities in populations, particularly our Black heritage population, where the vaccination uptake is lower than these figures. As I say, we are working in partnership with the council to address that. Vaccination very much still remains open for all of these cohorts whilst we are moving on to the lower ones. So we still continually are encouraging patients to attend, and I think, you know, our goal is 100% uptake, because that's really what we want to achieve for our patients. So sorry, just moving on to the next slide.
Yeah, I just added this slide in to show the impact that vaccination is having on our frontline staff. So we were asked to identify people who were frontline health and social care staff, and of the ones that we identified, we've had a really positive response from the vast majority of them. We think that the figure for transport appears to be a little bit low, but a lot of the people working in the transport team had been invited because of their age or their clinical vulnerability. So we're not quite picking that up, but we are having another look at that. but we've been pleased with some of the team's uptake, and we're doing further work to identify some of the reasons that some of the staff might be a little hesitant. And I have to say that one of the reasons that has come out across North West London, both for health and for social care, is a reluctance of some of the younger women to have the vaccine at this stage, because they're either currently pregnant, trying to get pregnant, or concerned that they might get pregnant and don't want to have the vaccine. So when we talk about vaccine hesitancy, it's not all about myths and misinformation. Some of it is about the right information, and it's just not the right time for some people.
Lovely, thanks, Carol. So just in terms of our priorities over the coming weeks, our focus on continuing to get maximum population coverage, working in partnership with Voluntary Community Centre and Harrow Council to deliver a community engagement and communication programme focusing on vaccination hesitancy to increase our coverage of these most at-risk populations. And we will be starting our second dose of the vaccinations from early March, because we are now at the 11-week period since those first doses were given in December. So our centres will become very busy managing those second doses as well as continuing first doses for our new cohorts.
Yeah, we've done lots of raising awareness about vaccination as well. We've done lots of tweeting. The leaflet, well, the page on the right-hand side is out from what's it called? Homing In, which goes to all of our council tenants and people living in social housing. So there's a few facts in there about COVID vaccination, and another push to remind people about the webinar tomorrow night.
So I was asked just to talk a bit about access to primary care over COVID. This feels like it's been a really long story to summarise in one slide, but it's really just to highlight where we are now and some of the changes that have happened. So looking back to the first wave of COVID, so April and May last year, as people will know, very rapidly our general practice services moved to a virtual first model. So that's not that their practices weren't seeing patients face to face, they were, but we put in a lot of new technology and new systems so that initial triage of patients could be done virtually as a way of protecting our practice teams as well as patients from COVID infection. During this time, we were also rapidly adopting new measures of infection prevention and control within general practice so that patients were seen very safely when they came in. So that was all the PPE, as well as things like Perspex screens within practices, and making sure waiting areas had appropriate social distancing. There was huge support to care homes at this time and continues to be. General practice at this time, we're doing a lot of work around identifying their clinically extremely vulnerable patients and looking at ways to support them. And we put in place a number of home visiting services at that time as well for patients that were shielding and not leaving their house even for attending medical appointments. We developed what we are now calling COVID hubs that at the time were called hot hubs. So for patients who were ill with COVID, but in the community, not quite at the stage of hospitalisation, we developed a specific service that was operating out of Alexandra Avenue site to support those patients in the community, and that continues to run now. All of our essential services did continue at that time, and we also developed quite strong plans around business continuity. So looking at how practices could buddy up with each other and also work at their network levels to support the continuity of those essential services where they were either experiencing sickness of staff due to COVID within the practices, or real surges in demand from patients that needed urgent care. There was actually very few instances where we had to enact those plans at that time, but what it's really helped is practices thinking more about how they work together, and in those few instances where we did need to enact the plans, it meant that it could be done safely and smoothly. We then did move into our first stage of recovery between May and November. We retained our virtual first model within that, and really focused general practice on addressing that backlog in outpatient services, as well as looking at key services where there may have been some pause in delivery. So areas such as child immunisation and cervical screening, really focusing on getting back up to our pre-COVID levels with those essential services. General practice also played a really key role in terms of supporting patients with long-term conditions. Diabetes in particular in Harrow was a significant COVID risk factor, and we have really significant prevalence in our population. So actually looking at services to support and proactively reach out to those patients. And of course, a focus on mental health and well-being of our population was essential in terms of the impact of lockdown. So just as recovery was running, we then entered our second wave of COVID. I think the learning from the first waves enabled this to almost be quite a seamless move. Although I won't underestimate the pressure that has been on health services, including general practice, over recent months. But we did and do have the infrastructure in place to manage this very well straight away this time. So of course all of our infection prevention control measures were in place. Our virtual control model was already in place. We managed to move general practice swiftly to the delivery of essential services only. And really that was then to support both the urgent care needs of patients, but also to release practice staff to deliver the vaccination programme as swiftly as we could. Our COVID hub had been retained to support people managing COVID in the community throughout this period, and we extended their opening hours as a way of supporting patients and to take pressure off of acute services. And we also extended the services that are offered through our the GP access centres that operate from the PIN and Belmont, so that patients could get even more straightforward and smoother access to urgent care, and we could take pressure off of our 111 service and A&E services wherever possible. We are starting to make a move now to recovery from this second wave. Clearly, the vaccination programme is still very much of a focus in general practice, but we are easing off in terms of the urgent care needs and responding to emergency care for patients. So we are now starting to look at how we start addressing recovery from the second wave. Just pause for the next slide. So I think I've probably covered a lot of this, but I think it is just important to emphasise that as we entered the second wave of COVID and vaccination started, there was an explicit ask of general practice to remain focused on the delivery of essential services, but to stand down other services that they could, so that the capacity could be freed up to respond to the public health emergency that we found ourselves in. These essential services really focused on the diagnostics and care for patients with cancer, with stroke, with mental health, as well as delivery of preventative services such as baby vaccinations and cervical smears. I've included the list there in terms of guidance that we gave to general practice in of the essential services that they were asked to retain. And then we asked them to reconsider their priorities for other routine work and keep a log of those activities that could be picked up as part of recovery, which, as I say, we are working to now. There are a number of practices who will say in reality for them nothing changed and they continued to offer everything they did before this pandemic. But some examples of services that were stood down, and we're going to come on to talk about online consulting, but things like the monitoring of online consulting and getting practices to send that data, as well as some of the more proactive services where we ask general practice to actively identify patients with long-term conditions by asking them to come in for particular tests. We stood those down during the second wave as well, both to release general practice capacity, but also to avoid social contact where it could be for a few months as we went through this second wave. We're expecting over the coming months that sort of business as usual for general practice will be reinstated. And then finally, for me, just to, I know that there has been an interest in the e-consulting model. So this is part of our virtual model, just a part of it. General practice is operating through telephone consultation, through video consultation, but there is this option of e-consultation as well for patients. Some patients are finding this really useful. It is one route into primary care that we are monitoring and evaluating and thinking about how it works for practices as well as patients. And online consulting was always part of the digital strategy for primary care to improve patient access into general practice based on how patients really wanted to do that. So in practical terms, patients use online tools to access primary care services. So people can enter symptoms, descriptions of sort of what they're contacting their GP about, and they're able to receive advice, or it can be a route into booking appointments as well as a result of those symptoms. So it's a way of contacting the practice. Sometimes patients will get an email response to that online consultation, or they would receive a phone call or being asked to come in for an appointment. And as a CCG, we have committed some additional funding into our primary care networks just to look at how they're developing online consulting and improving the utilisation of it. So we do have 3 different systems operating in Harrow GP practices. Really what sort of comes out the other end into the GP practice itself is very similar. It's the platforms that just look slightly different for patients that are using that. So we have an e-consult system that's used by 11 practices, and we've got some figures there around the utilisation of that. We have a clinic model, which is used by 21, so the majority of our practices. And then we have one practice, which is a part of a larger chain within a proprietary system of general practice, and they use a program called Dr. IQ. As I say, we have stepped down the monitoring of this, so actually our view of exactly how this is being used and what this is being used for is more limited as a CCG at the moment, whilst we've stood down that monitoring. But we have got some data that we've looked at. So in general, we're seeing the common reasons for people using e-consultation as general advice or administrative help. So that's sort of about 28% each of those consultations, and others is for sort of dermatological issues. We are e-consult uses user surveys to measure patient satisfaction with this. And 75% of patients using e-consult are saying they felt their issue has been dealt with and they didn't need to contact the practice again. So that's really beneficial for the patient, but it's also beneficial for general practice as well in terms of actually using their resources more efficiently. And as I said, we have put additional funding. As we start to move back to normality, we will be working again with our primary care networks around how they're using that funding to develop this offer, and we'll be able to report back in more detail then.
Right, and Angela's just going to give an update on staff resilience.
Thank you. Thanks, Carol. Good evening. Yeah, so I was asked to update on our staff resilience. So for staff within the council, obviously we benefit from the council's support to all staff and the employment offer there. But on top of that, so there's the corporately pulse surveys have been done to gauge the staff wellbeing. So that's gone out to all staff just to see how they are. So we've been able to work on the results of that within adult social care. And we've had focus groups held by our principal social worker with all the frontline staff in June and July to discuss the impact of working remotely, particularly with that focus on wellbeing. And as a result of the feedback that we've got from that, we've drawn up action plans with good practice examples, and we've ensured that all our senior managers have been involved in addressing these issues raised, and that's been drilled down to a team level so that you have that very kind of bespoke response to teams who experience it differently across adult social care. We've been able to, as I say, promote the council's resources from all the different professional bodies, the Association of Social Workers, NHS, Keeping Well, and our colleagues in Mind have been particularly helpful about ensuring that we've had access to courses. So managers have been focused on wellbeing in their daily meetings with staff, their weekly with the teams, and in their one-to-one supervisions with staff. So the feedback we've had from staff is that some have been feeling isolated. A lot of people are attracted into social care because they like people, they like interacting with people. So a common issue was that they're feeling isolated. And so we developed some online social events such as quizzes, lunchtime coffee breaks, exercise classes, just to try and improve that contact. As a council, we've introduced Wellbeing Wednesdays, which is an opportunity for staff to be able to participate in either an exercise or a talk, or an opportunity to be able to look at their own wellbeing. We've encouraged work time flexibility. Many of our staff have been looking after homeschooling, looking after elderly parents. And so we've encouraged that flexibility to be able to cater for that. And managers constantly continue to promote wellbeing and the resources available, and to make sure that staff feel connected and they're able to have some flexibility. So if they are feeling overwhelmed on certain days, that they can step away. And so that's for the Adult Social Care Council staff. I was asked for feedback on in terms of the resilience for staff in care homes. So you might be aware that in Harrow we have 33 independent care homes. So these are different organisations run these care homes, and they're CQC registered. So many of the organisations would have their own response to be able to support staff and their resilience. But one of the areas that practically all registered providers work with is an organisation called Skills for Care. So this organisation is there to support the registration, support the managers, and they've been particularly proactive, this organisation, in ensuring that staff have resources to be able to draw on across the board. So that's accessed through the NHS websites, Mind, and they have sort of 5 steps to wellbeing, which they promote as well. So as I say, that the good organisations do follow that guidance. And that's it from me. Thank you, Carol.
Yeah, so I think that's the end of our presentation, and I'll open it up for questions.
Thank you. I think I'll start this time and then bring on everyone else. This is about impact of COVID-19 on Harrow communities. Is there a local program of engagement to bust myth and targeted communities? What are the key messages that councillors can reinforce with residents?
Yeah, I think we do have quite a lot of engagement activities. So as I've already mentioned, the webinar that we have tomorrow night. But in addition to that, there's one going on right at the moment with the Tamil community. and there's one on Friday that we're doing with the Somali community. So every week we have a lot of engagement. We have we got almost £500,000 for our Community Champion Fund, and we're using that to work with communities so that they can actually engage with us, find out from their community what some of the concerns are, clarify what the real answer is, and be able to feed that back into their communities. And I think that's, you know, that sort of co-production model, you know, bringing information from the grassroots into us and telling us, you know, what people feel like, because we haven't got all of the answers. You know, we need to recognise that the communities have a lot of those answers themselves. But you know, we want to try and help them in whatever way we can. So we've helped so far in making videos with communities, and doing some leaflets and translations, as well as holding these events. So I think from a counsellor's point of view, I think you have an influence in your own wards, and people know you, and I think getting some of those messages across about how important it is to stay isolated, especially now people are seeing that light at the end of the tunnel getting brighter. They want to run towards it faster, and we have to ensure that they still stay safe for the next, you know, month or so, and then things will start opening up. But they'll only start opening up if people actually stay safe at the moment. So I think that's one really important message. Testing is another important message, whether it's testing because you haven't got symptoms but you're out of the house, or testing when you have got symptoms, and then vaccination. And the vaccination is it's safe, it's effective. The more and more information that we're getting about the vaccine, the better it seems. I'm being vaccinated on Thursday and I can't wait. I'm so pleased it's my turn at last. It feels like I've been waiting forever for this. So I'm hoping to make a little video when I go to get my vaccine, so that I can encourage people to get vaccinated as well, and show them that it's safe. And yeah, it's about leading by example, isn't it?
Thank you, Carol. Are there any challenges, barriers forcing in rolling out the vaccination program? How can we mitigate the impact of these?
Don't know whether Genevieve wants to pick that up, or Lisa.
Sure, happy to do that. Hello, everybody.
Hi.
I mean, I think that there are lots of challenges in terms of making sure that we have individual conversations with people. So I think there are people such as Carol and myself who are bashing down the door to get the vaccine, but we know that's not true for everybody. And I think, as Carol pointed out in her presentation, there are a number of different reasons why people feel that way. And what's really important is it's about having those individual conversations. So I think using the term vaccine hesitancy is a really good term, because it is often just that people haven't had the opportunity to do their own thinking around a vaccine, or they're lacking information, or they're getting information from sources that perhaps aren't the most validated. So the conversations I am having with people when they're unsure are really, first of all, taking a step back and saying to them, tell me what your concerns are, and listening to their concerns and listening to information that they have read or assumptions that they've made, and then actually giving them the other the other point of view, and making sure they're well informed with the right information, and then really leaving it to them to decide. This is not a situation where you can badger people into having a vaccine. This is a situation where we very much want to listen first and then move forward with giving people the right level of information. And actually, it may take a few times, it may take a number of conversations, it may take a bit of time to pass for people to think and reflect. But in the main, people are very responsive to having the conversations, because I think people really want to know the truth, and sometimes they are in family situations where there are opposing views within a family, and sometimes they need to have a counterbalance of somebody outside the family to help them make the right decisions.
Okay, thank you. Now the next one is on the vaccine. What is the vaccine uptake among health and social care frontline staff in Northwest London? Is there any analysis to highlight disproportionality with regards to, say, staff of BME backgrounds?
I presented in the presentation what our percentage uptake was. Obviously, that covers the people who are employed by the council. What we haven't been able to do as of yet is to get some ethnicity breakdown of that data. From our anecdotal discussions, we know people from all ethnic backgrounds have had the vaccine, but we don't know whether it's skewed in any way. So we still need to do that work. I haven't seen any data on the health staff, and we're really keen to get the information on the domiciliary and the residential care staff, because that's where our uptake is a little bit lower than we would like, and so we do need to do a bit more work with people who work in that sector.
What about staff working with mentally ill patients and, of course, learning disability? It seems that staff are vaccinated, but the users are not. Do you know why?
That's a really interesting one. So I think that we do know that we've absolutely offered the vaccine to members of health and social care frontline staff, and as Carol said, some people have taken us up on that opportunity. Other people are still wanting to find out a little bit more before they take it up. The JCVI, which I think is an acronym none of us knew, to be honest with you, 4 months ago, and now just rolls off my tongue. But the Joint Committee for Vaccination and Immunisation have made their decisions about who should have the vaccine, and they took a very strong line in terms of wanting to go down the age criteria first. And I think that initially that has meant that some of our learning disability and mental health patients have not come into the original cohort of vaccination. Much as some of us may dispute that decision, it is their decision to make. And the government has very much gone along with their recommendations, as they are themselves a statutory body. But as we've moved, as Lisa was saying, into cohort 6, where cohort 6 is for people who basically would normally have the flu jab, that has enabled us to start to offer the vaccine to members of our community with perhaps non-physical conditions. There are some people, for instance, those with Down syndrome, who are actually in the extremely clinically vulnerable category because they were felt to be at an increased risk of picking up the infection. So they would have had their vaccine in, or should have had it offered in group 4. But we are definitely picking up much more of our learning disability and mental health population. But we also have to remember that one of the vaccines you can't immunise under the age of 18. The other one you can't immunise under the age of 16. So for our most younger populations, we're still not in the ability to vaccinate them.
Thank you. My last question. The Health Watch Harrow report highlighted an increase in complaints about GP access and waiting time for appointments. How is this being addressed in surgeries? There are concerns that new way of working for surgeries can exacerbate digital exclusion as more people are asked to use online means to access GP services. How is this being addressed? Are surgeries planning to change their model of appointments or to fewer face-to-face appointments when the pandemic has over? I don't know.
So yeah, it was. I had a really useful conversation with Marie from Harrow, Health Watch Harrow, and it's some fantastic work they've done to get that patient feedback, and we are looking at it. So I think the reality is, over the last few months, patients probably will have experienced some challenges in getting GP appointments, and essentially we have asked GPs to do that. So for non-urgent issues that can wait a few months, in order for us to deliver this vaccination programme, those patients have been asked to wait, and we knew that would result in some complaints, but it was what we had to do to respond to the public health emergency we face. I think there is a bigger issue here, isn't there, though, that it's not just about the last few months, it's about a long time people have been accessing their GPs in a virtual way now, and only being seen face to face where needed. I think it really needs to be looked at carefully. The digital exclusion side of it, it is telephone access in the main that general practice is operating, and online consulting is there as an option, and video consulting is there as an option, but the majority of practices I speak to are running that initial contact through telephone and then telephone consultation with patients, and then seeing them face to face if needed. So I think there's an issue if patients don't have access to a telephone, but I hope that it isn't a purely digital offer that practices are giving. But it's very interesting the work Health Watch Harrow have done, and we do really need to monitor this to make sure we're not excluding groups of patients going forward.
Can I also say that I mean, I actually don't like it either, if I'm really honest. I like talking to patients face to face. I feel really frustrated that I can't offer a normal consultation to some people, but actually I hold myself back from doing it because I don't actually think it's right that my need to talk to somebody face to face means that I'm putting them potentially at risk to go into the surgery, and that would feel wrong because it would be my need. And I think what is surprising is that you can actually do a lot of contact with people by telephone or online or by video. So I think that we're all a bit frustrated, if I'm really honest, by the system, but some people really like it. And I think going forward, there will definitely be a group of people who it is appropriate for, or when people want particular things, it's appropriate, and when it's something else, it isn't. So I think it will become another tool in our toolbox to pull out for the right people. But I can't wait to actually go back to normal general practice. But I don't think it's ever going to be quite the same, I'll be honest.
The question is, if you have to see the nurse, you can go to your surgery and see them, but you can't see your GP. And sometimes it's like it's over a year since I've seen my GP, and it's frustrating that I want to see him in person rather than, you know, all over phone and whatever. Yeah, I haven't had
probably
any
equally frustrated, but
Yeah,
you see the appointments that the nurses offer. So some of our nurses are working virtually. They might be shielding, so on and so forth. So there are things that nurses do that can be done virtually, but there are other things predominantly that need hands-on care. You can't do it unless you're actually face to face. To be honest with you, doing the vaccine program's been such fun because I've actually had to speak to people and talk to them and stick needles in their arms and that sort of thing. I can't do that through the telephone.
Yeah, thank you. Okay, everyone, please don't repeat the questions. I hope you've listened to questions I've asked. I'm going to start with Michael Borio, then Natasha, then Janet, then Leslie, and then Veena. Thank you.
Thanks, Rekha, and thanks everyone for a really interesting presentation and update tonight. I just wanted to ask it's actually a couple of questions related to vaccine uptake. Firstly, Rekha did cover my first point. It would be good to get the stats for BAME uptake in those the earlier cohort groups. But also, second question really is about the, I believe, the split between those who are working in frontline health or in social care. In terms of the uptake, I think the figures are around something like 70-30. I'm not sure what the figures are for Harrow, but I think it would be good to get a sort of a further breakdown, if possible, of those who are refusing, of why. For instance, is it because they've got a principled objection, or is it because, as Carol pointed out, you know, particular issues in their life at that time, or there might be medical issues as well, like allergies, for instance, why they can't have the vaccine. So that would be useful to get the data. And just my final question really is looking ahead in terms of the next cohorts. Now, I know the JCVI is meeting that apparently is going to release the results later this week of where they see the further cohorts beyond the first 9. And I think a lot of the reports is it's going to be on an age basis. So you're probably going to have like 40 to 49, etc. as you move downwards. And what I was wondering is, sort of thinking ahead really, the most challenging age group is probably going to be the under 30s, and there's a lot of evidence from polling that the uptake that they've shown a lower willingness to have the vaccine. And there's also some evidence as well. We've obviously had a very successful vaccination program, I think, so far in the UK. They've also had a very good program in Israel, and some of the evidence has shown there in polling that, for instance, is that there's a much lower willingness to have the vaccination amongst under 30s. And I know some of the ideas is they're thinking outside the box, like looking at setting up vaccinations in social settings. I mean, an interesting idea I saw the other day was for instance, with clubs and bars where people could go in and in exchange for a free non-alcoholic drink, you know, you could get a vaccine. And I'm not necessarily suggesting, obviously, that's going to, you know, be something for over here, but are we thinking about, you know, how are we going to really encourage that age group of under 30s to get the vaccine, and how, and, you know, how are the ways that we could do it, particularly sort of thinking outside the box? All right, thank you.
Thank you.
So just to respond, yeah, I can absolutely have a look and see if we can give you a further breakdown on that data and share maybe some of that softer intelligence as well. I know the teams have been doing a lot of work with care home staff around vaccination uptake and really sort of, you know, really listening and addressing concerns that people have and turning some people's decisions around to have the vaccine. So absolutely really happy to share that. I love the ideas on the under 30s. I have to admit, I feel still in a fog of the age groups that we're doing at the moment. So I am aware that these are challenges that we have to address in the not too distant future. The work's been really focused on the immediate and necessary right now. But it is something we need to start turning our head to. Part of me wonders if travel passports for once you're vaccinated might make a difference in those younger cohorts, if that is introduced and allows greater flexibilities around, yeah, what you can do, whether it's abroad or in this country. But thank you for the suggestions, and yes, it is what we need to turn our heads to next.
Yeah, Michael, it just reminds me of going back 20 years when I used to work in Camden, Islington, and we had a young men's health clinic upstairs in a pub in Hampstead, so that we were trying to encourage them to be a bit more proactive about their health, and offering sexual health services and access to condoms as part of the HIV programme. Yeah, we've done it before, and I'm sure that we can do that sort of thing again. Yeah.
But can I just say, I also think that I'm sure you weren't saying this anyway, but we are actually very fortunate with a lot of young people who have actually been incredibly responsible during this period of time. And I think that some of the research now that's coming out that's demonstrating that vaccination can prevent transmission will be a really positive reason for younger people to obtain vaccination, so that they can perhaps go out and meet their more older members of their family with a degree of certainty. So I think that there will be a need for a range of different responses that are focused on a bit of carrot, a bit of stick, and really, the more that we demonstrate to people that having the vaccine is as simple as walking into a nightclub and still being able to have a drink and a party, then actually that's a positive. So it's not a big deal having a needle stuck in your arm.
Thank you. Natasha, please. Hi.
There we go. Yeah, that is just also reassuring. Thank you so much for all those updates. And yes, I think Genevieve, I completely agree with what you're saying there about the sacrifices people have been making and stuff like that. And I think just speaking from experience, some of the younger people in my family, they've been very much wanting all the older people and those that are vulnerable to get their vaccines, and saying, well, if you get yours, then maybe I won't need to have mine. And then they're like, well, I'll get it done. I'll get it done if I need to. So yeah, I think you're onto something there. I've got a question, but I just thought, as a bit of feedback, Lisa, when you were talking about the digital services and things being on the phone a lot of the time, just again, speaking from experience, my granddad's GP is in Stanmore, and he just could not get through on the phone. He didn't tell any of us, and then when I found out, he was like, it just rings and rings and rings and rings and rings, and then nobody picks up. And this was really at the peak of when things were bad across the board. And it was just going dead. And I've been using online access for things for years now, and I said it's really easy. And as soon as I went on the portal and just put in a request to say, can a doctor please ring me, like saying this is from blah blah blah, he got a phone call back straight away. So and then he was fine. He's happy to do things over the phone. So I think it's definitely onto something there. It's about, this has been such a learning curve for everybody, and it's looking at what's worked and what can be tweaked and how we can make it even better. I've loved having more access to things online, but that is reflective of my age demographic and that I do everything online. But again, he's very happy to. He just didn't know he could as well. I said, if you go on the website, you can do this. So again, I think it's an education piece. But yeah, anyway, that's my question. I know that the JCVI, and it's all about the different priority groups, and it's going so well. From my experience, I'm clinically extremely vulnerable, and I was getting letters to get vaccinated, and I got calls from my hospital that isn't in Harrow and from my GP. And I had to book mine and then rebook it because my doctors then said, no, you can't have the vaccine that close to your medicine. You have to have it 2 weeks after. But it went really, really well. And again, my family, the rollout, all the older people have been vaccinated now, every single one of them, including some of the younger ones as well. So my question is, moving away from kind of those categories in terms of complete health reasonings, back to the key worker question. It's probably a bit, crystal ball-esque, but seeing as how we've added more people to the list and things have been shifted around, do we think there is any prospect of more people being added to the key worker list? With schools imminently going back and things like that, do we think teachers and other frontline people in that sense will get added, or do we think that we are still so inundated getting through everything that there's not much chance? Thank you.
Yeah, I think vaccines are created for one of two reasons. The first reason is to stop people who were infected from being more severely infected and stop them dying. And that was the principal reason for doing this vaccine. To prove that a vaccine stops a person transmitting the disease takes a lot longer. And that's what we've been waiting for that evidence. That evidence is now starting to come through and is looking very positive. So with knowing that it was effective to prevent people from dying, then you focus it on the people who are most likely to die, most likely to end up in hospital, most likely to have long-term outcomes. So that's the reasoning behind the first set of cohorts. I think now we've got more evidence when JCVI resits and takes into account this evidence. There may be a subtle change to actually start looking at key workers, but at the moment, I don't think that there's any plan for a huge change. But I think if the evidence keeps going the way it's going, in that it reduces transmission, then the people who are most likely to transmit it are the people who are in contact with lots more people. Mm-hmm. So the argument for key workers, I think, becomes really strong then.
Thanks, Carol. Yeah, that makes complete sense. Thank you. Yeah. Yes, and I just want to say as well, so I had my first dose last week at Byron Hall, and it was just fantastic. It was so well run. I think across the board, everybody I know that's had their vaccine, no matter which site it's been in Harrow, it's everybody should be so proud of the response and how it's gone. So yes, huge well done to everybody involved. Basically, thank you.
Thank you, Janet.
Thank you, Rebecca, very much. In fact, part of my question has already been asked by you and Michael. Okay. Residents have asked me, are being concerned about the take-up of the vaccinations with care workers in care homes and also in the community. And they're very worried that their relatives are coming in contact with people that haven't had the vaccine, and they're very worried about transmitting the virus. And I know Lisa said she was going to look into it and see what data she could find. Thank you.
And can I just add, before we go any further, I've suddenly thought I've got to declare a non-pecuniary interest. I'm a insulin-dependent diabetic and on kidney dialysis, so I have an interest all the ways round.
Thank you.
Thank you. So I did manage to find the data on our uptake from care home workers while we're on this call. So that's at 64%, which isn't as high as we'd want it to be, really. So we're sort of when we look at our our residents, that we are probably looking at over 90%. The care home staff are slightly lower than where we want to be. We have put in place.
But I have to say, Lisa, that is higher than flu vaccine, because flu vaccine was only about 45%. So I think we have managed to persuade quite a considerable number to have this vaccine. And I have to say, it's more than I expected at this point.
Definitely, there has been a phenomenal amount of work from Carol and team, from our local GPs in really sort of taking time to come to forums to answer questions. We're offering the care home workers the vaccinations when we go in to do care home staff, as well as access to all of our local centres, as well as the mass vaccination centres and the hospital sites. So there is something else, but yes, that the uptake is not as high as we want it to be, but is not bad, and comparably with other boroughs is high. But we'll continue to engage staff, and I think some of this can be a sort of about people waiting and seeing, and we'll be going back into the care homes to do the second doses in the coming weeks, and I think that provides another opportunity to re-engage the workers and see if people have had a chance to think about it some more, and whether they would like to take up the opportunity for a vaccine as we're coming back in.
That's lovely. Thank you very much for the encouragement, and long may you continue. Thank you.
Sorry, excuse me. Chris reminded me I'm a diabetic type 2, so I should declare, Andrew. So please take it as my declared, interest. Thank you. Dr. Les Lewinson, your question, please.
Yes, yes, I'm coming.
Thank you.
Just to say, I'm also type 2 diabetic.
Okay, so you're declaring that, yeah, okay.
Okay. I just was interested in the Barmy community because I know a number of Black people in the Black community are suspicious, hesitant, and quite anxious about taking the COVID vaccine. And I was just wondering, how many invitations do these people get to come to take the vaccine? Is there a cutoff point?
No, they can have as many as they want. We will talk to them at any time, and we will make it available to them at any point. So we have said that there's a range of different ways that we're making contact. So we're making contact by text. Everybody will get a letter to one of the mass vaccination sites. So they'll get it through the post if they haven't already had their vaccine. But we're not, we keep on going back to people and saying, you know, is there anything else you want asked? Or it may be people who have had COVID in the last 4 weeks who can't have the vaccine. So we need to go back to them 4 weeks later and check to see whether they're able to have it. But we are you know, is the word insisting? Possibly insisting. We are insisting that we make contact, at least a GP phones people and actually has a conversation with them, because some people would respond better to a clinician phoning them than somebody who's a non-clinical person. So we're trying a range of different options, but it is certainly not a kind of last chance offer, you don't get offered again. That's definitely not what we're doing. Yeah, I actually just want to pick up something that Councillor Borio said earlier about people who had allergies. So just to reinforce that, actually there are very, very few people who can't have the COVID vaccine. And initially we did think that people who had a history of allergies needed to be very cautious. In the main, that is absolutely not the case. So if people have got allergies and they have been staying away from being vaccinated, it is definitely worth a conversation with their doctor, because there are only a very few people who can't have the vaccine from an allergy perspective.
Thank you for that, Genevieve. I just was interested in that because my own brother, who is on kidney dialysis, he had 4 invitations before he decided to take it up, and he was sort of phoning me and asking me questions about, you know, the vaccine. So that's why I wanted to know if there was a time lag, a time span for people not to have it. But thank you very much for that.
You are demonstrating the point of how important it is for us to continue to have that contact, and also to ensure that people have the time to phone their relatives and get advice from them too. So thank you for doing that.
Thank you.
Rebecca, can I just say I had my one, and then I got 2 more invitations for 2 more. I'm doing pretty well out of it. I could be so vaccinated, best in the world.
Over efficient.
Okay, Veena, you have the question. Veena, you're on mute.
I hope you'll, very good presentation. I hope you'll share those vaccination slides. I've got a couple of questions. I know Leslie has touched upon that, and you say that you are sending letters out, but I've had some residents saying they've not heard from their GP practices, or NHS has not contacted, and they just get anxious that why they haven't been called, and they've been asked not to ring the surgery. So are they getting missed, or are the letters going missing, or are
so possibly is the answer to that, because you know the records are only as good as the records that we hold. So people may have a mobile phone number down incorrectly, or they may have changed their mobile phone number and forgotten to tell us, or they may have moved and perhaps forgotten to tell us that. That happens quite a lot. So it's possible they've gone awry. But as you will probably remember, I think it was on the 6th or 7th of February, Matt Hancock did say to everybody over the age of 70, if you haven't already heard, please make contact. So previously we had said don't make contact because we didn't want to answer, 80,000 phone calls, to be fair, but now we were getting to the stage where we could say to people, if you haven't heard, do make contact. So if your constituents are above the age of 70 and haven't heard, or they're in the clinically extremely vulnerable group, I would definitely encourage them to phone their GP and make sure that we haven't gone awry with one digit or another.
Yeah, only problem is like also the constituents complain that they keep on holding the phone and no one answers the phone.
But they can do, and so I mean, let me be honest here. The phone lines are only as good as the number of people that are there to answer them, and we have been hit by sickness and self-isolation and all of the things that everybody else has. So can I say that we're all answering the phone as quickly as we'd like to? No, I mean, I think that's true. But I have to say that, as Councillor Proctor was saying, if people can send us an e-consult or whatever the online thing is, then actually we know that people are getting through, and we will then phone them back. And sometimes people literally write as little as, I haven't had my vaccination, can you phone me? We're straight on it.
Okay, lovely.
I say, Genevieve, that's exactly what happened with my granddad. So sorry, but just before Christmas, all of the people, he's in his 80s, and all of his friends had been called for their vaccine, and he still hadn't heard anything. And I was like, Granddad, I'm sure they know that you're in your 80s and you will hear. But it got to kind of mid-January and he still hadn't heard. And I said, well, and I spoke to somebody else, and he's in very good health, my granddad, like, thank goodness. And so I think they were prioritising the people that were more vulnerable than him still in that age category. But again, like I say, as soon as I was like, I will do it for you online, and I sent them the message, and then they called him the next day and he got vaccinated, I think 2 days later. So, but it was a similar situation, I think, to that, as you're saying, Vina. He was getting really worried that they didn't know how old he was. And they got to him, but yeah, that's what happened.
Yeah, it's good. But also some Kenton West residents are old and they don't have sort of access to computers, or they don't have any relations. And so they are not really happy that everything is going online and they haven't got computers. So how could we help them?
Now I've got quite a few patients who write me lovely little notes, actually, which is always so lovely and charming. And they put them in the letterbox or pop them through the letterbox and say, can you give me a ring? I mean, the truth is, yes, we want to be there for all eventualities, but sometimes we don't get it right. That's the truth. But I think that we are, as Lisa said, general practice is open. We look closed, to be honest with you. I think it's awful. We look closed, but we're in there. We're working, and so it's just a question of kind of like we are honestly doing it to try and be safe with people, not to be obstructive.
I do understand.
But it is such a difficult balance.
True. 2 more questions. I really appreciate. I'm really happy that Harrow Borough is doing so well with our vaccination program, and we've been sort of on digital and social media. So well done to all the team who are volunteering and helping out with vaccination. And we've got quite a few, several hubs. One complaint I've had from some volunteers that a short notice, Byron Hall doesn't get a supply of vaccine and they have to shut. So like, was it last Friday or Friday before? They didn't have any supply. So all of a sudden they had to close on Friday, I think Saturday, Sunday, and I think they reopened on Monday. So why is the issue, who supply, is it NHS who supplies the vaccine, and why is it's always Byron Hall? Because I don't think Hive and Rayner's Lane have any problems. So if you could just tell us why Byron Hall is always suffering.
So it definitely is not just Byron Hall. We get this feedback across all three of our sites. So the supply chain is much better than it was at the start of this programme, but no, I think we all thought by this point we'd be delivering vaccines 7 days a week, 12 hours a day. We're just still not there yet in terms of the supply being released. And we have quite limited control over it locally. So we sort of get a spreadsheet that comes out a couple of days before the vaccine's arriving sometimes, and it will tell you the date of delivery and which sites are getting what vaccine. It's starting to get a bit more of a 2-week view that helps us plan, but that is the way it's running through the central NHS team at the moment, and it's quite hard to influence. As I say, it is getting better, and what we are encouraging sites to do is not to book clinics until they have that absolute confirmation of the supply date. It does make it hard work for the sites, and also quite stressful, particularly where it's Pfizer vaccine, and that needs to be delivered within 2 or 3 days because it's got quite a limited shelf life. Yeah. You've suddenly got to fill 1,000 appointment slots with 2 days notice. It is quite stressful. So sites can sometimes anticipate when they think the supply will be, or they're told, they think, okay, it's coming Monday, so I'll book in patients from 4, but then they'll find out it's not coming till 6 and things have to move around. It is problematic, but what it should move to in the future is something called so at the moment they're calling it a push model. So this is where the national team push out the vaccine and you're told you're getting this on this day with quite limited control over it. What the hope has been is that it will move to a pull model where the sites will be able to say what they need, and how many sort of patients are left within the cohort groups we're operating, and so they can proactively order it and know which day that's coming. So we hope that's a change that will allow those sites more control. But yeah, it's a real shame, and particularly for the volunteers who are giving up their personal time. Apologies on behalf of the NHS for that we haven't quite got it right yet, but it definitely isn't just Byron.
Yeah. Just last question. Carol, thank you for your presentation. You mentioned 18 to, was it 39 age group? They are sort of like, I don't know, are they spreader or are they infected? And how are we going to be addressing that situation?
Yeah, it's 25 to 59. Is the highest rate, and basically that's the majority of people who go to work are going to fall into that category. So people who work on building sites, people who we've still got taxi drivers and bus drivers and health and social care workers, people who are essential, as supermarket workers, they meet a lot of people during their day job. They'll use public transport. So it's not surprising that they are the highest rate at the moment. What I'm more pleased about is that we're seeing in younger adults the rates starting to go down, because that was certainly our very high group a little while back. I think that that group is going to be the last group to come down, which is why anybody who's going out to work or who spends time outside of the house needs to have that asymptomatic testing.
Last one, for the schools are opening, they're going to be doing all this lateral flow. Where's all the data going to be sent? And who is going to be managing the results, so we get some analysis, how many children are positive or negative or tested, and how often will the schools be testing those children?
So the plan at the moment is that in the first 2 weeks, the schools will do 3 tests on the children, secondary school children, secondary and further education children, young people, I should say, in the school at the school site, and they will be shown how to do their specimen, how to prepare it, and we'll be given all the information about what to do. The 4th test in the 2nd week will be one that they do at home, and then thereafter children will be given test kits to do at home in the same way that the teachers are going to do. So there's a sort of training element for the first couple of weeks. I have to say, you know, I have some reservations about people doing home tests, because we know that the effectiveness of the test reduces with people who are not used to doing it. But because this is a programme that's going to go on for a long time, and we're expecting people to do this on a regular basis, they will get better at both taking the sample and in preparing it. So the effectiveness of the test will improve. We're talking at the moment, because literally this is like hot off the press. I only heard at lunchtime. So we're talking at the moment about how we can support schools to be able to do that, because you can imagine some of our bigger high schools have got thousands and thousands of kids to test. And they're not going to be doing any teaching, because they're just going to be testing kids for every day. We're talking about how we can support schools to maybe use some of our lateral flow capacity, like St Anne's or the Temple in Stanmore, to have kids go up there and get tested there. So we do some of the training with them, so it take a bit of pressure off some of the schools. So it's all new, and it's all sort of watch this space. But yeah, it's going to be an interesting few weeks.
Yeah, so it's going to be.
I think I've been saying that since about last March.
Yeah, it's going to be rapid testing and not PCRs.
Yeah, and the plan is that it will be even more widely available. So you know, there's likely to be community hubs where people can pick up tests to do at home, rather than going to community testing centres. Yeah, I think we're in another period of change as with regard to testing, but all of the data. So when you do the home tests, you log the test on your phone, on your smartphone, and scan in a barcode, I think. At least we think this is how it's going to work. So you scan in the barcode like you do in the testing centre, and that will log that test to you, and then you put in the result at the end of it. That then gets sent over to Test and Trace, to the central database, and anybody who's positive will be followed up by Test and Trace. They'll also tell the school, they need to tell the school that they're positive, so the school can take the appropriate action if they need to isolate anybody else. So it's pretty much going to work. That part is going to work out the way that we've already got it in place, and schools are really used to doing that.
Yeah, good, lovely. Thank you very much, Lisa, Carol.
But I suppose if you know that your children have symptoms, or then it's best that not to send children to school.
Definitely, if the children have got any symptoms, then they should be taken for a PCR test, and you book that through the gov.uk website, and go down to South Harrow or come to the Civic Centre mobile unit. So any symptoms at all, get a test as quickly as possible. But it's just for those people who've not got any symptoms that we're doing the lateral flow.
Okay, sorry.
Lovely, thank
Just
you very
two
much.
people on the screen. Sorry, Simon and Dr. Nirali. Nirali, do you want to ask anything, or you just appeared on the screen?
Well, no, thank you, Chair. Just a couple of things. Firstly, I'd like to emphasise the importance and the priority that we give to contacting all the various communities, as Carol and Genevieve have mentioned, that our engagement, Carol and our engagement community engagement team are working really hard to make sure we get the message across to, as Carol said, the Somali community, through the Somali community voluntary organisations, the Tamil communities, and also our role as councillors, talking with our contacts in the communities, indeed using local celebrities. Well, I'm talking about Navin really, making videos in Gujarati, and other colleagues who across the council who have been contacting their own communities and explaining in the relevant languages, in Tamil, in Urdu, that the message is take the vaccination. So we're really homing in on that. We are in constant conversations with our service providers in the domiciliary area to make sure that we can explain and get information through to all the staff that do our home visits, and along with the GPs who've done a fantastic job in the care homes, because whenever they go in to do a mop-up, as it were, because as Genevieve says, people that have had COVID have to wait 28 days before they can be vaccinated. So when the GP goes back into the care home to vaccinate someone that's had their 28 days, they'll engage with any of the staff members that are there that have been hesitant before to see if they can persuade them. So that's really good. And I really would like to thank the really hard work that's been going on since March by the staff in the Civic Centre, by Harrow Council staff, by staff in our providers, our care homes, all our health colleagues, all the GPs, all the people that work in that sector. They've really gone well beyond the call of duty. And I have to say, they're starting to be weary, they're starting to be tired. It's been going on a long time, but they put in a really big effort, and I really would like to say thank you to them. A couple of things that have come out and we've got to look at going forward. I think first of all is the increasing the number of patients presenting with mental health and well-being issues and difficulties, and I know that was mentioned in what Lisa was saying, but we have to think about have we the capacity, and how do we help and get the right treatment for this increase, which is not unsurprising, but for this increase that we've seen there. And also, as other members have said, digital first means digital first. It doesn't mean digital only, that we have to have methods of enabling that part of our population, our residents who don't use digital, perhaps can't afford broadband, just don't use computers, to be sure that they're not excluded in any way. And then just to end, to say, well, the results of the going down, the rates going down, but we still must be cautious, because from Carol's graph, I think the rates that we're showing today are the same as the rates that we were showing in the last week of November last year, when we were still in tier 3, was it? So we've really worked hard, everyone, to get the rates down, but we're not there yet. So we've still got to be cautious and follow the rules and distance and wash our hands and wear a mask and everything else until we've beaten this thing. Thank you very much, Chair.
Thank you. Let's hope we'll get there soon, very soon. Okay, Dr. Nirali, would you like to say something, or?
I just want to apologize if I've been switching off my video and switching it on again. Believe me, simultaneously, I had to do a presentation to the Tamil community at Sri Lankan Cultural Center that asked me to give a talk on the same issue. And I'm thankful to Carol. Until this afternoon, my figures were going to mention that the incidence rate in the past 7 days is 263, until I saw Carol's slide now, just before I went away, and it said 118. So I was able to give those great new set of news. So thank you very much. It has been very useful. we've all been trying. I'm doing my bits wherever I'm invited to talk at the community level. But I salute to everybody in Harrow Council and everybody within the CCG for remarkable work that has been done so far.
Thank you. Right. Sorry, are there anyone want to ask question? I think I've covered everyone, but just come forward and say, I want to say something. Okay. Thank you very much. It's nice to see so many people, real people, to say, because you are on your own, 2 people in the house and you don't see any outsiders, or, it's nice to see all of you. And thank you very much for being, answering all the questions, and we had great dialogue. So I'm very grateful to all of you. Of course, we have one more item, but if CCG is leaving, then just wanted to say thank you for coming to everyone.
Thank you very much.
Thank you.
Thank you so much.
Nice to see you all.
Nice to see
Take
you all.
care.
Bye.
Thank you. Okay. Can we can the subcommittee note the update? Then we can move on to last item. Thank you.
Yes.
Okay, item 9, update from Northwest London Joint Health Overview and Scrutiny Committee. Any questions? Like to talk about, discuss anything? The report is there, of course. Hope everyone has seen it. Yeah. I think next meeting is in March. Yeah, in March, isn't it, Veena? Next month. Yeah. So.
Breaker, your camera's disappeared.
Is it? I'm still here. Everything is hi. I'm there.
I can see your profile picture, but not your video.
Oh, my camera is on. My speaker is microphone is on. You can't see me now? Well, luckily we are at the end, but I'm here on my surface. I can see myself there in the corner.
Have you pressed
a picture of you?
Have you pressed the video? If the video camera's got a line through it, you might have turned it off, but you can still see yourself.
Now I've done that. Now, can you see me? No?
Yes, we can see you.
Oh, great. Thank you. Well, we've come to the end of the meeting. So all I would like to say is, sorry, any other business, AOB, or any other urgent business? I haven't been notified of any. So thank you very much to everyone attending and for your contribution. Can I close the meeting, or anyone want to say anything? No? So time is 9:07.
See you.
Thank you. Bye.
Meeting closed at 9:07. Thank you to everyone. Thanks, Carol.
Bye.
Bye all. Thank you. Thank you, Carol.